Sincerest thanks to SAGES for the opportunity to present our work comparing the safety and cost effectiveness of conscious sedation and anesthesia provider-based care in endoscopy. We have no disclosures. In the United States, approximately 17 million endoscopic procedures are performed annually. This is associated with a total cost of about $30 billion. Moreover, endoscopic procedures generate significant additional revenue for healthcare systems, owing to the further imaging, additional procedures, and pathology evaluations that these endoscopic procedures generate. Historically, anesthesia for endoscopy has been provided using conscious sedation, a combination of sedatives and analgesics that is usually administered by nursing staff. However, over the last 10 years, the healthcare community has demonstrated significant interest in the use of propofol for sedation during endoscopy, owing to improved procedural sedation and shorter recovery times with a similar safety profile compared to conscious sedation. However, in many hospital systems, propofol requires an anesthesia provider be present for administration. Given the additional cost associated with the presence of an anesthesia provider, begs the question, why use propofol that requires such additional costs? Healthcare systems argue that the faster procedure turnover associated with using propofol outweighs additional anesthesia-related cost. And as a result of this faster turnover, more procedures can be performed per day in the endoscopy suite, generating overall additional revenue. The objectives of this study were to compare the safety and cost effectiveness of conscious sedation and anesthesia provider-based care for endoscopic procedures. A University of Louisville IRB-approved database consisting of outpatients who underwent endoscopic procedures between 2013 and 2017 was used for this analysis. Patients were categorized based on the type of anesthesia that was provided during their endoscopic procedure. Conscious sedation provided by nursing staff in the endoscopy suite, or care requiring an anesthesia provider. Procedure types comprised EGD, colonoscopy, and ERCP. Groups were compared with respect to patient demographics, procedure variables, anesthesia-related complications, including the need for post-procedure intubation, the need for post-procedure admission, and procedure-related costs. Overall, our patient cohort consisted of approximately 1,400 patients. The procedural breakdown of these patients is seen here. Among patients undergoing EGD, conscious sedation was associated with a significantly shorter procedure time and a significantly lower procedure-related cost compared to anesthesia provider-based care. Among patients who underwent colonoscopy, conscious sedation was again associated with slightly shorter procedure time. However, it was associated with an increased recovery room and post-anesthesia care unit time compared to anesthesia provider-based care. It was, however, associated with lower procedure-related costs compared to anesthesia provider-based care. Among patients who underwent both an EGD and a colonoscopy at the same setting, conscious sedation was again associated with a longer recovery room and post-anesthesia care unit time, but a lower procedure-related cost. It should be emphasized that among patients undergoing EGD, colonoscopy, or both EGD and colonoscopy, there were no difference between the two groups, conscious sedation and anesthesia provider-based care, with respect to anesthesia-related complications, need for post-procedure intubation, or post-procedure admissions. Finally, among patients who underwent ERCP, conscious sedation was again associated with a longer recovery room or post-anesthesia care unit time, but a lower overall procedure-related cost. Again, there were no difference between the two groups with respect to anesthesia-related complications or need for post-procedure admission. On multivariable analysis controlling for age and patient comorbidities, Among patients who underwent EGD, conscious sedation was independently associated with a shorter endoscopy suite time and a lower overall cost. Among patients undergoing colonoscopy, conscious sedation was independently associated with a longer recovery or PACU time, but lower overall cost. This was similar among patients undergoing EGD and colonoscopy, as well as in patients undergoing ERCP. This study should be interpreted in light of several limitations. This is a retrospective single-center analysis with a very experienced endoscopy suite staff, including a set of very experienced nurses and endoscopists. Additionally, the decision regarding use of conscious sedation versus anesthesia provider-based care was based on attending preference and thus subject to selection bias. Limited data was available regarding indications for procedures and complexity, which could have confounded both procedure-related time in EGD and colonoscopies, as well as overall procedure-related costs. Finally, no patient satisfaction data was available to compare the two groups. In conclusion, for outpatients undergoing endoscopic procedures, conscious sedation and anesthesia provider-based care afford comparable safety profiles. Conscious sedation is associated with lower procedure-related costs. However, it's also associated with longer post-procedure recovery times. Future studies should aim to delineate the optimal algorithm for choosing anesthesia among patients undergoing outpatient endoscopy. Thank you very much.